Over to you, Shelley. Oh, you're muted, Shelley.
Thanks. We are so pleased that we have our special guest from Alberta that could join us today. This is certainly a plus for virtual connections and opportunities for sure. I've had the pleasure to connect with both Dan and Melissa virtually through some lectures as part of a virtual rehab course at the University of Alberta. And certainly we know that the work in Alberta with their community stroke ESD program is well known across the country. So we are so happy they agreed to be with us today. Melissa is an occupational therapist and the clinical team lead for the Stroke Early Supported Discharge team at St. Mary's Hospital in Camrose. In 2017, she completed the University of Alberta Certificate in Stroke Rehabilitation, which included a final project proposal on determining if Skype for Business was an effective means of enhancing stroke early supported discharge services for rural stroke survivors. Melissa has a special interest in enhancing best practice and access to rehab services for rural clients. Dan is a PhD student in rehab science at the University of Alberta and teaches an introduction to the telerehab course for clinicians. He is a physiotherapist with experience across several practice areas, including acute and community stroke care, and is currently working in private practice in Camrose. I will now turn the session over to our speakers. Welcome, Dan and Melissa. The virtual floor is yours.
Great. Thank you so much, Shelley, and thank you to everyone for joining today. So to start again, just wanted to give a special thank you to Shelley and Heather for organizing this session from the Ontario Stroke Network in Southeastern Ontario. It's a real privilege to speak to you today with my friend and colleague Melissa Styzm, as we're both in Camrose and have worked together for a long time. So we're really excited to be able to share this presentation with you, and you'll hear from Melissa shortly. So. And also, some of you are joining by phone, and thank you to Shelley for sending out those PDFs so you can have a look at the slides later if you're joining, and this might be kind of like a podcast for you if you're in your vehicle. So so on the first slide here, some of you might feel a little bit like this picture. Suddenly we've been pushed into this different way of connecting with our patients because of different types of access barriers with the pandemic. So it can be overwhelming. Even today, using Teams might be the first time you're using Teams. This is my first time using Teams. So every platform has some different features and a bit of a learning curve. And that's for us as clinicians. And then also we have to think about the learning curve for our patients too. And it's a new skill for everyone. So patience is definitely an important thing, and keeping in mind that this is a new skill set for everyone. So today we'll be looking at just talking about what COVID means, I guess, in terms of a shift in practice. We'll talk a little bit about the background from Melissa and I's, our point of view. We have been advocating for telerehab services for a long time. I think conversations, Melissa could correct me if I'm wrong, but I think we started to have conversations about this in 2014. And it did take a long time, and Melissa has done a tremendous amount of work and advocacy for getting approval for use of telerehab with our patients. And then, we have the COVID situation, and then overnight approvals happen where, before it was a really slow moving machine, and now we're seeing much more rapid, I guess, adoption of telerehab or need for telerehab. So we'll go over some of the terminology, just some definitions. Briefly discuss one of the systematic reviews in telerehab and what to think about and use in the evidence when you're looking at evidence in telerehab. And then Melissa will talk about a specific, more practical example of using telerehab in our early supportive discharge program, looking at different disciplines. So we'll highlight some examples for you of some examples of how we have used telerehab with speech, rec therapy, I believe, or social work, and physiotherapy and occupational therapy. And then we'll go over some of the lessons learned, things that maybe we wish we knew when we started, but are happy to know now. And then we will talk a little bit about future practice, and then we'll stop the recording and open the floor up for questions at the end. So just to start with, I think the common theme of telehealth in general and telerehab is access and overcoming barriers. And for us, Melissa and I, living in a smaller kind of rural setting, distance was the main driver. So we, as an ESD team, we're traveling long distances and spending quite a bit of time in our vehicles commuting to see patients, and that was where the initial drive for starting telerehab services began. We our travel time, increase our therapy time, and so that's was the heart of it for us. Some of you might have seen patients who don't have access to rehab, and it can be really difficult or kind of heartbreaking to see people. Maybe they've been discharged from hospital and they haven't received additional follow-up care, and you just know by meeting them that they could probably have be more functional, or maybe they've been sent home in a wheelchair, for example, and they need ongoing therapy to progress to a walker. So people who don't have access to physio services, to OT services, to speech services, we know it's a real disadvantage, and that's really, access is really the heart of wanting to do this. And this could look different for different populations as well. So our new reality is the virus. So it's really shifted our thinking, of course. Unfortunately, we can't really even have any conversations today without bringing this new reality up. But we're happy we have this technology that at least we can connect with our patients in some way to deliver quality care, and that's also, we don't just want to connect with patients, we want to deliver quality care and try to make that care equal to or better than what we would do in person. So before COVID-19, we had a slow emergence of telerehab practice, and Melissa will talk more about our service delivery with ESD. But it was really challenging to advocate for the use of telerehab. I don't know exactly how long it took to get approval to use our first platform that we used was called remote presence desktops. So that was a telehealth type of technology. And then we moved to Skype for Business, and that took a long time to get approval signatures from our corporate organization at Covenant Health. So, and eventually we did get approval thanks to Melissa's persistence, but it did take a long time to get up and going in terms from the time we had the idea to actually being allowed to implement services using Skype for Business. So the pandemic response has shown how valuable I think virtual health can be to maintain access to health services, especially those in self-isolation. And now even a 6-foot distance could be a big enough distance to keep us from seeing our patients. So the use of virtual health has really come to the forefront in the last few months. And as with any new practice area, there's a need to ensure we are providing evidence-based practice. So we want to make sure that the decisions we make in using virtual health are based on research. I think that gives us confidence in knowing that we're providing the best care we can. And that definitely has a learning curve associated with it. And clinicians, though, are still experts in your area of practice. So you know what type of therapy that your patients need, and now we're looking at changing the way that we deliver those services. So always, remember you have obviously the expertise to treat patients. It's just changing the way that we're providing those services. Our professional team has been working to support the shift in clinical practice with virtual practice guidelines and mentorship. So Melissa's been working on those, and those were also attached in the email sent out from Shelley, some of the work that's been done with Melissa's team on looking at outcome measures that can be used and the evidence in telerehab practice. So with the current pandemic, it has expedited uptake of virtual health, but there's still challenges. So we have approvals to use it, but from a clinician point of view, there are some different challenges that we're facing in terms of not having maybe enough education and the use of telerehab, and having challenges with different the features of different platforms like we were mentioning earlier on. But I think it's important to, when you're making decisions about how to deliver care, to think about evidence-based practice using the research available, thinking about your experience as a clinician, and then also the patient values. And we know that telerehab might not be appropriate for every single patient, but there is a big group of patients who telerehab is absolutely a great service delivery method. And then also, I'd encourage you to think about your messaging around telerehab. So how you're explaining why you would do this. I've heard from a lot of clinicians it might be framed as, well, we'll try this, or so it's really, I think patients really will follow what messaging they're here. So if you talk about the evidence behind it, once you have experience in it and you can share your experiences, successful experiences, maybe some of the challenges that you've had, I think that helps clients make a more informed decision about the use of telepractice. So I really like this quote in the area of virtual practice and telerehab, and that in the beginner's mind, there are many possibilities. In the expert's mind, there are few. So I think it's really important to really keep in mind that we're all beginners, and not to kind of close off certain ideas. So really use that evidence-based practice framework to guide your decision making. Thinking about, again, your clinical experience, your patient's preferences or their background, along with the evidence. So just some of the definitions to give some clarity around. You've likely heard the terms telehealth and telemedicine used interchangeably. So the difference between these two terms is that through consensus, the term telehealth is generally adopted as more of an encompassing term that relates to all subdisciplines, including telemedicine. So telemedicine is kind of a subset of telehealth, and telehealth is this overarching field of delivering care at a distance. And other disciplines such as rehab fit into that, and then even more specific types of practice areas such as telestroke or maybe teledermatology, teleradiology, those types of specific services all fit under the telehealth umbrella. And today, of course, the focus is on telerehab, and there are several different terms describing telerehab. So you might hear telespeech, teletherapy, virtual therapy. So there's a lot of different terms, and that's okay. And you can use the term in Alberta. We're using the term virtual health, so it might depend on the region that you're working in. But in general, the idea is the same behind all of these different terms. And generally across Canada, most allied health regulators have adopted this type of term for telerehab. So it can be defined as the delivery of professional rehabilitation services at a distance using telecommunications technology as the service delivery medium. So telerehab relates to the services delivered by allied health disciplines, featuring all aspects of patient care, including the patient interview, physical assessment and diagnosis, treatment, maintenance activities, consultation, and education like we're doing today, and training. It can include mediums such as the telephone, video conferencing, email, apps, web-based communication, and wearable technologies. Personnel may or may not be present with the patient at the far end. And it should be noted that this definition was also adapted from the Physiotherapy Alberta's Telerehab Resource Guide. So it's initially this definition was developed for physiotherapy, but I think it definitely relates to all rehab services. And I really like this definition because of the fact that it features all aspects of patient care. So treatment, assessment, diagnosis. When you're looking at evidence-based practice or appraising the research in telerehab, there's a few things that you should take into consideration. So for sure you want to take into consideration the level of evidence that you're being presented with. So is the evidence coming from a systematic review? Is it a randomized controlled trial that we tend to trust a little bit more? Is it an expert opinion, case control study, or smaller cohort study? So that's important to keep in mind for sure. In some cases, though, when you do want to find evidence on a specific outcome measure, it might not be there. So there might be, you might have to rely on your clinical experience to adapt an outcome measure to provide with your patients, which can be a little bit scary because you don't have the research to back your assessment findings, and you might be unsure, are these outcome measures that I'm performing over or over telerehab or virtually, are they comparable to my traditional in-person assessment? So some questions to ask yourself in those situations, I'd start with safety. So some of the assessments that I look at in terms of balance, I would make sure that there's a person present with the patient at the far end. I wouldn't do a balance assessment with the patient on their own at the far end. I'd also think about the impact that assessment has on the patient. So is funding dependent on the outcome of this? Is it a pediatric patient? So there could be some different challenges, or the weight of your assessment findings might vary depending on the tool you're using. And so you'd want to make sure that the assessment you're providing is accurate. So those are some things to think about. When you're looking through the evidence in general, another thing to look at would be, in a lot of the studies, you'll find that the telerehab research, the assessments are performed in person still. So the kind of baseline assessments are performed in person, and the after intervention assessments are performed in person, whereas the intervention it's performed using video conferencing. So really look at that. So a lot of times the assessments are still performed in person in telerehab research. You'll see the majority of research is in intervention. There is some in assessment as well, but it's less. There's less studies looking at assessment in telerehab. There are several dedicated journals to telerehab and telemedicine. So there is an international journal of telerehab that comes out quarterly from Pittsburgh. So you can subscribe to those and get a list of the articles that come out sent to your email. There's also the Journal of Internet Medical Research that has a division of rehabilitation and assistive technologies. So there are some specific rehab dedicated journals to telerehab that would be nice. I subscribe to those, and it's nice just to even get the headings and see what's coming out, and once in a while click on that if that pertains to what I'm doing in my practice area. So in Canada, we're lucky to have our stroke best practice guidelines, and there are some guidelines related to telehealth and telerehab. So first, in our team, we really wanted, again, to look at rehab intensity and reduce our travel time. So we started with kind of looking at this guideline that in-home stroke early supported discharge services should be provided at the same intensity as inpatient rehab services. So we know that we should be providing care, and in our ESD team, we try to provide care 5 days a week for a minimum of 1.5 hours per session. So and travel can get in the way depending on our caseload. So virtual health gives us a way of cutting down our travel time and hopefully helping to meet those levels of that are indicated for our patients with stroke. We also have some evidence level C. So those are mostly from cohort studies. Clinicians should consider the use of telemedicine in the care of patients post-stroke. So there is, in our best practices, that is included. And I'm sure you will see this level of evidence updated shortly. This year has had the most new research in telerehab compared to previous years. And every year the evidence is growing. So I think you will start to see more evidence coming from systematic reviews or level A evidence. Also, all rehab disciplines should consider the use of telemedicine technology or telehealth technology for patient assessment and clinical therapies, and also a level C evidence. And home-based patient monitoring through web-based applications may be considered as an alternative to face-to-face clinic visits. So there is some support that we can use tele-rehab and virtual means for assessing and monitoring our patients, and they can be really effective means of doing that. So one of the systematic reviews is just listed on the slide here from 2018, and it was looking at it included about 22 studies. Most of these studies included in the systematic review were on motor recovery post-stroke. A couple of the studies were on post-stroke depression using telerehab, and then there were some studies included looking at supporting patient caregivers as well. And so I would encourage you to have a look at this this systematic review. Systematic reviews are a great place to look at the journal articles that they cite. So you can go back to the original research and have a look at how those studies were done and get some ideas in terms of what types of interventions were used and how those interventions were run. And the concluding statement, which was interesting from this article, was that this so this was an update. Systematic review provides evidence to suggest that telerehab interventions have either better or equal salutary effects on motor, higher cortical impairment, and mood disorders compared with conventional face-to-face therapy. So that's where, as a clinician, at least I want to go back to those original studies because I want to know, like, when you hear terms like better effects than in person, that can kind of raise some eyebrows. So I think it's good to look at those, how they measured improvement. But I think overall you'll find a lot in the research that telerehab interventions typically have at least equal improvements with our patients and satisfaction with our patients compared to face-to-face. So maybe there's still a debate about whether they're better, but I do think there's some confidence that you could say with the right program, you could achieve equal results or outcomes with your patients. So just some drivers of telepractice. So this slide is just looking at cost and access. So if we, right now maybe we're kind of in a higher cost healthcare, medium access. So or kind of, and then what we're trying to move as the cost of technology decreases, which we're already starting to see in terms of access to technology. The future state in an ideal world would have a low cost technology, which we're seeing, and high access. So that's kind of what we are aiming for and trying to reach our patients rurally or patients who are unable to attend in-person or traditional practice. So next, I will turn it over to Melissa to talk about the ESD program in Camrose.
Thanks so much, Dan. Dan's, as you can tell, has a lot of expertise surrounding evaluating the literature and considering what might be appropriate to our clinical practice. And so I would suggest any hard questions at the end, you really direct Dan's way. All kidding aside, we'll start to talk about, we'll discuss telerehabilitation implementation and within Alberta. And it's really important to know that in Alberta, almost 40% of our stroke survivors live within rural communities with really limited access to rehabilitation services, which I think I've heard is quite similar perhaps across Ontario. And so for our Camrose team, our monthly travel, it really ranged from 7 to 15,000 kilometers, depending upon our caseload. And then our management team actually estimated that 6% of our travel budget deficit, was within those first few years. So we really needed to start looking at more efficient ways of providing service. And due to the demographics of our community, a number of our rural clients in our caseload at any given time exceeds those within the city limits, really creating this huge, this big travel barrier, we could say. We were quickly learned that geography significantly limits our rehabilitation intensity, as Dan mentioned, affects our caseload capacity and our clinician efficiency. So that for those of you who can see the slides or have access to them, you'll see in the figure here, it really depicts our travel range and then our rural communities that we've served. So Skype for Business implementation, as Dan mentioned, it really paved the way, was paved the way by a previous project showing the successful use of in-home telehealth video conferencing. So as Dan mentioned, in 2016, we completed an 8-week pilot project using the same telehealth software that some of our stroke neurologists use to provide telestroke consults to our rural primary stroke centers. And so at that time, when we were doing that project, after much advocacy, as Dan mentioned, we actually had assistants equipped with laptops, cameras, and speakers that traveled to client homes to connect with therapists over telehealth. And so that project really supported video conferencing used to augment our services, and it really set the stage for further investigation. Um, and so in the figure here, you'll see the black markers show where in-home video conferencing has been successful. And in some instances, we were actually able to start to stretch our geographical borders to provide greater services to clients that otherwise we wouldn't have been able to provide service to those people. And the goal is always to provide in-home rehabilitation at the same intensity as inpatient rehab. But we must do within our current budget constraints. So we'll just give you a little bit of an overview of our ESD team. We're a transdisciplinary model of care to provide client-centered, goal-focused rehabilitation. And the team is comprised of 8 different disciplines who each provide discipline-specific expertise while working on client-centered SMART goals with one common transdisciplinary rehabilitation plan. With the exception of our 2 full-time assistants, all clinicians are part-time, having full-time equivalencies between a 0.4, so that's 2 days a week and 3 days a week. So our cameras team with the travel, each clinician, is equipped with laptop, iPhone, and external camera and puck speaker if we go out to see our clinicians. And then we'll start to talk a little bit more about how we've adapted that, and we're truly using a virtual model without those initial home visits. So as we start to think about how to implement or continue to use virtual health for an ongoing service delivery, as Dan mentioned, it can seem really overwhelming and a little bit daunting to begin with. So at a program level, our team used lean methodology to really help guide us in our virtual health implementation. We were able to start mapping the current state to identify and eliminate waste. We determined how and when virtual health could be appropriately integrated, and then we worked to perfect the process while identifying value created. So engaging in ongoing program evaluation, it was really critical to ensure that quality patient outcomes were maintained regardless of the mode of service delivery. Our team has really found that integration of virtual health to provide a mixed model of in-person with virtual augmentation, it really can, in fact, enhance client outcomes and improve therapy intensity while creating efficiency of staffing resource utilization while decreasing travel. And additionally, despite our clinical bias of in-person preference, our client satisfaction of virtual health has proven to be really high. So we'll talk a little bit more about that. And on this slide, you'll really see our preparation or prep, triaging over the phone. Traditionally, pre-COVID, we would get into the home to begin with to help set up, assess the home environment. We would really start to do some in-home assessments, and we'd set up virtual health. And then we move kind of into a virtual health model and then finish in the home. But throughout the pandemic response, we've really shifted that around. And just yesterday, I was working with my team to do some more quality improvement, and we actually were, initially when we did our process mapping, virtual health and Skype at that time was sort of towards the end of our process mapping, and now it's really right at the beginning, right at the forefront. As soon as we're preparing to take a client on, we're truly determining what their virtual rehab capacity is from a client perspective, and looking at those client factors and moving that virtual sort of appropriateness assessment right up to the forefront. So after our initial implementation, we really evaluated both process and client outcomes to compare, in-home telehealth versus at that time Skype for Business, and now we would say Zoom is sort of equivalent to the Skype for Business work that we have done. And the table that I'm showing on the screen, for those of you who can see it, it just shows travel time and kilometers saved. Of course, was really quite significant, and we all know that, of course, travel time saved would be quite almost twice as much when we're not having to send someone out to the home. And then that it shows the overall mild cost avoidance, which is, it really has a big impact on our healthcare system when we're looking at a stewardship looking at it from a stewardship perspective, and really trying to maximize the efficiency of our rehab resources. And then, the next table that we have here shows our client outcomes. So you can see that the COPM, the OSTOMs, and the FIM, we have found have all showed that performance is maintained regardless of service deliveries face-to-face or in the home, whether it's with telehealth with TA support or if it's clients using Skype or Zoom independently. So that was some discovery our team did on our own. That is not a research study, it's quality improvement, but it really showed our team what can be possible. And then, I have a couple of slides about satisfaction from a client and clinician perspective. And perhaps most importantly, to know is that client satisfaction was high with both Skype for Business and telehealth. I won't spend too much time on the details of the questions, but you can see the red bars here is agree versus strongly agree or disagree and strongly disagree. And most of our clients, regardless of what question we were asking in relation to virtual health, they were all agreeing that it was a worthwhile mode of service delivery. And again, with our clinician satisfaction, this is something that as a team and as a program, we really looked closely at. And at the end, 100% of our clinicians did support expanding the use of virtual mode of service delivery. So before we start discussing the individual discipline experiences, there are just some overall team benefits that all of our disciplines have identified and benefited from. So, to begin with, we would say that we've identified the benefit of increased staffing efficiency due to travel time saved. We have more client visits per day per clinician. We're able to see clients with little notice. So we can really address, urgent blood pressure concerns, medication questions. We've had a few falls that we've been able to address and really prevent an emergency room visit or rehospitalization. So that, from a system perspective, has a really big impact. Most interventions, if we've had an assistant on the other end, almost anything is possible. And really throughout the pandemic, we've been moving away from using assistants to utilizing a client support network already existing within the home, whether that's a spouse or a child, any type of caregiver who is able to help us on the end. We're able to help monitor staff, and as well as it provides a lot of options for vacancy and vacation coverage. As we know, our staffing, particularly in rural settings, can be quite difficult when we have those vacancies. We have fewer cancellations due to poor weather and road conditions. So if we were planning an in-person visit and we have a snowstorm like often happens in Alberta, we're able to quickly pick up the phone, arrange a virtual session, and at least provide some service. Our access to specialized programs has improved. So within Alberta, some of our specialized services such as spasticity clinics or neuropsychology, they're really in our urban settings, and often that's a barrier for our rural clients. So using virtual mode of service and clinicians support with the client, we've been able to arrange these appointments virtually, and it's really increased access to specialized care. We've done home care collaboration, and then it's also just enhanced our team involvement with care. So more team members are able to join in calls together, whether it be for a family conference or a discharge conference, and we're really able to collaborate a little bit more with our clients and their families. So we'll move into our individual discipline experience. And Dan and I today are going to speak on behalf of our team, but just know that there are many clinicians within our team that have quite vast experience. So we'd be very happy to help answer any questions that you might have. So our occupational therapist has been successfully using virtual health in many different ways. And some of the successes that she's noted and assessment are some of the assessments and screens that she started using. So, she's started using the Shadok for upper extremity, the Reach, MOCA, independent living scales, is able to assess equipment and also to look at splints. And, one of the things she would say is that observation and feedback is probably one of the most powerful tools that you can do virtually. So just, using virtual means to observe kitchen tasks, transfers, writing, reading, virtual perceptual tasks, upper extremity, exercise programs, that type of thing. You really can be, almost like a fly on the wall and observe the client within their home environment without a lot of interruption. We've also had a really good success with education and collaboration, like we've already mentioned. And then just some future considerations. We've talked about using document viewers to increase ease of viewing certain tasks. And we did a lot of advocating when we were using Skype for remote camera with a pan and Zoom function. We were able to do it, and Dan will talk about this within a research study. Now after a lot of advocacy, we do have one, but we found now that we've moved to using Zoom, which is applicable and available on all devices, including mobility devices. We haven't had to use that camera quite as much. So here we're just going to show a couple pictures of some of the therapy that we've been able to provide. And the majority of our OT assessments do not include, protocols for virtual administration. But that being said, we found some screens and assessments or portions of them that are conducive to being done virtually. So we don't necessarily get a standardized score, but we can use the information for treatment planning. And then again, here we're sharing these slides with client permission. We just show a couple more of the tasks that we've observed, from flipping therapy pancakes to observing tub transfers virtually. So just more examples of some of the things that we've been able to do. And I'm going to get ready just to move it over to Dan to talk about the physio experience.
Thanks, Melissa. That's awesome. So similar to OT, the kind of observing patients, so just screening patients. So sometimes we have referrals to our team that maybe PT is not identified as a main need, but we still want to connect with that patient. So sometimes that might just be a conversation or observing some of their functional transfers or their function in general. And then just doing things like a history, of course, is easy to do through video conferencing. Providing education, I think actually the virtual needs have is in some ways better than in person for education. We can do things like this. I mean, you can share slides and kind of visuals with your patients, draw on the visuals. So it's a really good teaching tool that you can use with your patients, and then provides a little bit easier access or collaboration with the PT. And like Melissa said, with a lower FTE, then we want to maximize our time and not spend as much driving. Observing gait can be challenging, so you need to make sure you have enough space to do that, and making sure the patient is safe. And then a lot of those cases, that is with a therapy assistant, unless the client's independent with ambulation. And observing exercise programs can be beneficial too. And now with Zoom being able to record the session, you could even record part of the exercise program and then share that with your patient, or send that to them as a reminder if they're okay with watching themselves do exercise. And some people don't like that, but it is a nice reminder. We've looked at some objective assessments. We did a study on the Berg comparing in-person to telerehab and found excellent inter-rater reliability between those two methods. So that was a huge success. Things like a dynamometer, or it gives a nice quantitative assessment of grip strength, so we get a number. And in terms of doing that virtually, that's fairly easy to do for sure. Looking at anti-gravity strength, so grading up to 3 out of 5 we can do remotely without providing resistance. And a lot of those scales are most reliable in that range anyway, but in the future might be things like using a handheld dynamometer or a biofeedback device to feel or observe a patient's strength remotely. And then TA support. So as Melissa mentioned, if there's any last minute things that come up, it's nice to be able to check in, and not only just on the phone, but just to see through the video how the patient's doing. And then we have also kept on some of our patients who traditionally, if we had to keep driving to see them, we would have to discharge them from our program. So we've been able to add a few more weeks of almost like an outpatient service where we see the patient once or twice a week, just to extend their therapy time when we feel they could benefit more, but we're limited because of just the system limitations, I guess. So the challenges for sure are still hands-on, assistance. So balance for sure is a big one in PT. Feeling muscle tone, feeling restricted to movement. We don't have our hands to feel what's causing the restriction, so that can be for sure challenging, and hard to walk somebody else through an assessment of tone remotely. And then assessments in general, I think there needs to be more work on those. But we, like Melissa said, we've had some success with our Shidok, like doing parts of the Shidok McMaster and thinking about adaptive assessments. Manual therapy we can't do, obviously. Really challenging our patients in balance, so we have to provide things that they are completely safe if they are performing the exercises independently. We really have to make sure they have a chair behind them or a countertop in front of them. So and whereas in person we might have them away from support and just spotting them, so we can't obviously do that. And sorry, the last one I can't. Oh, okay. So just, yeah, demonstrating exercises as well. So just having the patient, certain camera angles can be tough, but like Melissa mentioned, the mobile devices are nice because we can have better camera angles. So this was just an example of our setup for the Berg balance scale. So we had a clinician in our office, and then talking about measurement, we had to, for the Berg, one of the items is having the patient reach forward, and we have to measure that. And usually we'd measure that in person, but we needed a device to measure how reaching distance. So in this case, we have a project display board with these strips that are 1-inch strips, so we can determine how far the patient's reaching, and it really gives us an objective measure. And then, of course, we have a therapy assistant at the far end here to spot the patient. And in this case, we used a camera with remote control, pan, tilt, and zoom features, and that was huge in balance assessment because otherwise the therapy assistant will have to leave the patient, adjust the screen or adjust the camera, and that's really not safe. So it's nice that they can be totally focused on the patient, and I, as the clinician at the far end, or the clinician at the far end, can adjust that camera remotely. So that was a nice feature at that time, for sure. So that was just an example of our setup for doing the Berg.
Okay, and then we'll move along to just talk a little bit about our experience with speech pathology and social work for those of you on the lines of those disciplines. Our speech pathology, experience has been very successful virtually within our ESD setting, and they've said they really are able to do most formal and informal assessments with assistance on the other end. And just to note that we know some assessments are able to done virtually, without hard copies at the other end, for example, as there aren't always virtual versions of them. However, our speech pathologist really has been doing a lot more informal assessment now that we're not going into the home quite as consistently. And then after, initial in-home personal introduction or visit, prior to COVID, we were really able to establish the rapport and determine the client's environment and specific needs. And then and virtually we're able to continue to do treatment for most areas of communication deficits. And we would just note that, again, our speech pathologists are starting to do a lot more without that initial in-home introduction. So we're really learning a lot along the way. And, it's really an opportunity for family members and caregivers to attend and participate in the rehab sessions and to become, really a vital part of the rehab team. And, it is also an opportunity for clients, families, and therapists to discuss progress or concerns about programming. Um, and, our therapy assistants, we've talked about them quite a bit as they have, kind of been vital, but really any helper can support this process within the home. And, there are still challenges that we're learning to overcome, and for sure, clients with severe comprehension challenges or severe hearing impairments, it's quite difficult, or treating reading, and just if caregiver support is not available for some clients. But within our ESD setting, really we're focusing for clients that are, really that mild to moderate stroke severity, and so it does tend to work very well for them. And then as far as our social worker, you know, she's had quite a bit of success completing social work screens and assessments virtually. She's able to assist clients to access resources and community services, really being creative virtually with support, and continue to assess concerns related to mental health and provide emotional support, as well as quick screening for clients and their caregivers at a time that's truly convenient for them. Coming into a clinic is not always convenient for a caregiver or a support person when they need to access those social work supports. Some of the things that have been a little bit more difficult virtually, or is being able to build rapport and trust in a face-to-face session. So I think we're getting better at that as we're learning. But from the clinician's perspective, we always feel that that's something, that barrier to overcome. However, what we're hearing from our clients is that really isn't a barrier from their perspective. So it's just an interesting to hear perspectives from both sides. And then, of course, just engaging with their natural support network. So I'm going to just quickly mention, and we've shared these resources with you over email. With the rapid uptake of virtual health to support the pandemic, the Alberta therapists are really seeking practice supports to further inform virtual clinical decision making. So our provincial rehab councils work to develop guidance documents to support clinicians. So we've shared these resources, but know that they really are living documents, and we're updating them as knowledge becomes more evident. And then, we've shared lots of information focusing, on the success of virtual health implementation. However, just know that it wasn't always easy. It took a lot of advocation. It wasn't always smooth sailing. It takes a lot of perseverance, determination, and much creativity to really let it become successful. And some of our key lessons learned on a whole is just that age is not a barrier. Therapeutic relationships are not necessarily compromised. Rehab outcomes can be maintained. Telerehab tools enhances client education ability. Accessibility barriers are removed, and creativity is absolutely maximized. And so what we're most excited about is to see where telerehabilitation will take us in future practice. We know that equitable access to rehabilitation services has not yet been achieved. However, with this emerging technology, we really have the potential to bridge these gaps. And at the end, we'll just leave you with that we truly believe that we're at the very beginning of a paradigm shift in healthcare, and that each one of us on the call today, we have an opportunity to shape how rehabilitation practitioners embrace our technological future. We're starting to build the plane, but we all hold a piece of it as to how it's going to be built and the route it takes. So with that, I know we're kind of getting short on time for questions, but we'll hand it back over to you, Shelley.
Thanks so much, Dan and Melissa, for sharing your experience. Our Southeast region certainly is very new to virtual care and largely jumping in as a result of COVID. So very eager to learn from your experience. So we will now move to more of our open dialogue and question portion of our session.